Good afternoon. I am Dr. AMRITA Pal. Good afternoon to my seniors, my colleagues and juniors. I'll be speaking on this topic, the thrombotic primary angioplasty, which is, as we know, dangerous terrain to traverse. It is a place where we all are scared that this may not be good news. And nevertheless, we do encounter it in our daily practice. And so I'll go on with what we may encounter and how to tackle it. So the first thing is to identify the thing correctly. Are we dealing with a thrombus, or is it calcium, or is it a mix of both? So a thrombotic lesion looks like filling defects or haziness in an angiogram. Unfortunately, there's only 26% sensitivity in recognizing a thrombus. And everything has a classification, and there's been a score, thrombus score, suggested by this cardiologist, Hainos et al. And they've given 5 grades: 0 for no thrombus, 1 for possible definite thrombus, less than half of the vessel diameter, grade 2, less than half to up to 2 times the vessel diameter, grade 3, more than 2 times the vessel diameter, grade 4, and TIMI 0, or inability to judge thrombus burden, is grade 5. So we may use imaging. It should not be done routinely, but we may use imaging, and that will give us a very good idea. Are we dealing with a thrombus, or is it something else? It will also help us recognizing whether it is a red thrombus or is it a white thrombus. I'll go into that. So these are OCT and IVUS images of the same, and we can see some mass hanging, and that's how we identify a thrombus. So where should we use imaging, if at all? So if there's a mismatch between the angiographic appearance and the clinical presentation, we are not certain, and we need to know the exact burden of thrombus we are dealing with. So those times, not regularly. Now we come to few facts that we should know. So there's one study which tells us that 91.6% of primary PCI cases have thrombus in them. Angiography sadly underestimates them. 6 to 18% is the distal embolization rate we deal with, and that distal embolization depends on, will have a negative prognostic factor. It affects the success rate, it affects the post-procedural LV ejection fraction, and a larger enzymatic infarction. So it's good to be prepared. We should know how bad the thrombus is. Not only a thrombus can be a bad thrombus, it can be a not so bad thrombus. So we need to know the composition of the thrombus, and I'll tell you, I'll discuss how. The size is obviously, more the size was the case. The pre-PCI TIMI grade, larger vessel diameter and length. Target vessel length is more and it's full of thrombus, so it's a bad case we are dealing with. So the pathology of a thrombotic lesion. So it has been found from the thrombus aspiration catheter studies that an early presentation will have a platelet-rich thrombus, but a late presentation will have an MPO-rich and a more erythrocytic thrombus. So that is a bad thrombus. So the later the presentation, it's a more red thrombus, more erythrocyte and MPO-rich thrombus, and we need to be careful, more careful. It's a harder thrombus, it's prone to distal embolization, and it will give a worse result. So these are some of the pictures. The white thrombus we see down below. These are softer ones, easier to deal with, and the upper ones are the red thrombus. So what are the methods we have? Firstly, imaging, if we at all use it. Then wiring. Of course, we have to first insert the wire, pass the wire. Let's do it with workhorse wires. And if we cannot, then maybe the hydrophilic ones with a good trackability. If you are encountering that there is some hardness, there's some calcium, then we go for the hydrophilic ones. Next is drugs. So this is where we start with the GP2B3A inhibitors. We'll go more into the details. Then we go into the devices. That's the mainstay of dealing with a thrombotic PAMI. In spite of what the trials tell us, devices are important, and they really help to get out, to get away with the thrombotic PAMI. And lastly, intracoronary thrombolysis. So what are the drugs? We all know eptifibatide, tirofibrin, and abscisimax. And it can be delivered intercoronary, intravenous, or a mixture of both. And it's difficult to say which is more effective because reports vary. We have intracoronary adenosine, nicorandil, nitroprusidil, TSM, and in certain resistant cases, epinephrine. So what are the evidences in support of using GP2B3A inhibitors? There's this Clearway trial, which showed some improvement of the coronary flow and reduction of thrombus burden. And then this Cicero trial, which shows with the use of abscisimax, that the myocardial blast was improved and the smaller enzymatic infarct size was found. The thrombus aspiration remains a great debate whether to do or not to do. So what are we having in our hand? Multiple devices with dual lumen catheters. It should be passed along the culprit lesion and with a smaller lumen consisting of the guide wire and a larger lumen to basically aspirate by creating a negative suction. So two characteristics we need to remember: the deliverability. It is something which is a measure of the pushability and the trackability of the catheter, and the speed of aspiration. So whatever the devices that are in the market will tell us will claim better trackability, better pushability, and lesser and better rates of aspiration. So the Export AP and Export AP Advanced were the first ones used in the earliest trials. We have better, more improved, efficient catheters, like the Thrombustor 2 being used. QuickCat, they say, has the best features of all together. There's Eliminate and Pronto devices, and this CAT-RX, these are which was presented in 2019 and ACC, and it claims of a very good deliverability and trackability and faster clot retrieval and 0 stroke rate. So what does a safe and a successful thrombus aspiration involve? Firstly, we need to have a well-engaged and supportive guides. Then, while we are crossing the thrombus, we should aspirate so that there is no distal embolization. We should multiple time pass through the vessel, through the clot. And while aspirating, while removing the catheter, we should again aspirate so that there is no proximal spill or spill into the aorta, causing stroke. And lastly, the guide catheter should be completely cleared of any debris, remaining debris by back bleeding. So this is a image we all see, and this is a macro thrombus that has been retrieved by a thrombus aspiration catheter. So these are a few of the common devices. And so what are the support? What are the points in favor? They decrease the thrombus burden. We all know the lower rates of distal embolization. We get to see the actual landing zone for the stenting. We get to see the exact stenosis size so that there is no underexpansion. No reflow rates are reduced after stenting. We have lesser incidence of no reflow and improve microvascular perfusion. So better clinical outcomes in long term. So the original supportive evidence was provided by the TAPUS trial. So it was it consists of 171 patients, and the myocardial blast score was actually the primary endpoint, and it showed absolutely successful results. And the thrombus aspiration was hailed as to be routinely done in every case. But however, today with the 2000 as we stand in 2023, we have a class 3 indication of using aspiration thrombectomy, but this is not true. They're talking about routine aspiration thrombectomy. So what it says is routine aspiration thrombectomy before primary PCI is not useful, but that means clearly that in selected cases it can be done and possibly it should be done. The JCS also gives a similar standing, and so does ESC. So it's a bit of a dismal result, and that is derived from the TASTE and the TOTAL trials in 2013 and 2015, which are large trials involving many patients, 7,000 and 10,000 patients. And it showed that there is no reduction in mortality and MACE. And in fact, there is an increased incidence of stroke at 30 days or 1 year. So that's when it became less popular. But if we look closely, we will find that these studies, there is some problems, like the patient selection between the TAPS trial and the total and the TASTE trial were different. There were more comorbid patients were chosen. The timing and delay of reperfusion was never documented, and different devices were used. So with the newer devices, the results may not be as dismal. So this is the TAPS trial, which showed very good results with thrombus aspiration, and the TASTE and the total trial, which completely reversed the scenario. So it is the judgment of the operator whether to use or not use aspiration thrombectomy. We next have the intracoronary thrombolysis. This is an old concept. It was used routinely back then, but now in case of failed aspiration thrombectomy, we may use this. So marinade technique is a newer version of this, where we put a distal occlusion device, a small balloon inflated at the end of the thrombus, to marinate the drug, that is streptokinase, altiplase, or tenecteplase. These are the doses used, 10 milligram, 6.2 milligram of each, to selectively dissolve the thrombus. So that is the way it is used. And there's another newer technique I have found in the internet, which is from China, university in China, where they used a second wire along with the guide wire. They twisted the wire and they pulled the wire which had hinged the embolus within it. So this is how it is done. The second wire is rotated continuously in one direction, and the entire thing is twisted. The twisted material is totally taken out altogether. Next, we have direct stenting. That is, once the thrombus burden has been reduced by aspiration thrombectomy or reduced thrombus burden from the beginning, we can stent without predilatation, and this is called as direct stenting. It's better to use slightly oversize the stent in these cases, and post-dilatation better to avoid. If we have got a good TIMI score after the stenting, it's better to avoid it. So no reflow is something we find after relief of the coronary obstruction if the TIMI flow grade is low and the myocardial blast score is less. So what do we do in case of that? We use an IVUS to confirm. To prevent it, we avoid aggressive stent inflation, use a microcatheter for delivery of vasodilators, and use multiple vasodilator agents for refractory no reflow. So these are the agents used, and adenosine is a very good agent. Apart from that, the GP2B3A inhibitors, epinephrine in refractory cases, and we can come back to thrombectomy again, aspiration thrombectomy. So to sum up, my time is up, and I'll sum up with a flow chart. So let's cross the lesion with a wire. If a TIMI3 flow is achieved, good, we go for a aspiration thrombectomy if there is a high burden, thrombus burden. If not, direct stenting. If still the thrombus aspiration is not good, we can go for a direct stenting, or if not at all, then we go for a triple therapy and a deferred evaluation. Not recommended, but sometimes nothing can help. And if the TIMI3 flow is not achieved, again, thrombus aspiration. If not, go for the marinade technique, or if it is achieved, direct stent implant. So the takeaway is tackle it early before the clot thickens. There are so many ways, but there are no real guideline support in any of the methods. New technologies are coming up, and thrombus aspiration may not be as bad as it sounds. Intracoronary thrombolysis with distal occlusion may be a useful technique. Is there a role for laser? Yes. A new study called the Carmel study showed that higher the burden, it can be used. It gives good result, and operator skill and now is the last and the final thing that we need.